Thank you for answering the pre-test. Welcome to Ich So Makati, an online CPD on pediatric dermatosis. I am Dr. Maricon Escuadro Chin, a dermatologist. The objectives for this lecture are to explain the clinical manifestations and management of common pediatric dermatosis and to identify common pediatric dermatosis. The skin is the largest and most superficial organ of the body, and nearly one-third of pediatric outpatient visits involve dermatology complaints. Children and toddlers can suffer from a number of skin conditions that can make them uncomfortable and cause concerns for parents. Eczema refers to a range of conditions which involve skin inflammation. The most common of these include atopic dermatitis, seborrheic dermatitis, and contact dermatitis. Atopic dermatitis is a chronic, pruritic, inflammatory skin disease of unknown origin that usually starts in early infancy, but also affects a substantial number of adults. The following features should be considered in the diagnosis of atopic dermatitis in accordance with the Hanifin and Rajka criteria. Major criteria should include 3 or more of the following: pruritus, typical morphology and distribution, which includes flexural-like conification or linearity in adults, or facial and extensor involvement in infants and children, chronic or chronically relapsing dermatitis, or personal or family history of atopy such as asthma, allergic rhinitis, or atopic dermatitis. Atopic dermatitis is commonly associated with elevated levels of IgE and presents in a series of allergic diseases including food allergy, asthma, and allergic rhinitis. This has given rise to the atopic march theory, which suggests that atopic dermatitis is a part of a progression that may lead to subsequent allergic diseases at other epithelial barrier surfaces. There are some general patterns to where the eczema is found on the body according to the age of the affected person. Infants less than 1 year old often have widely distributed eczema. The cheeks of infants are often the first place to be affected by eczema. As children begin to move around, the eczema becomes more localized and thickened. Eczema in this group should often affect the extensor aspects of the joints, particularly the wrists, elbows, ankles, and knees. Older children tend to have flexural pattern of eczema, and it most often affects the elbow and knee creases. Treatment of atopic dermatitis focuses on interrupting the itch-scratch cycle. Agents typically used to treat atopic dermatitis include the following: oral histamine or colloidal oatmeal baths, unscented topical moisturizers. Inflamed lesions are usually treated with topical steroid creams or ointments, and the use of topical immunomodulators such as tacrolimus and pimecrolimus. Secondary infections due to Staph aureus are treated with oral antibiotics or topical mupirocin. Here is a sample algorithm in the management of atopic dermatitis. Please take time to read the algorithm. Seborrheic dermatitis is a papulosquamous disorder affecting the areas with most sebum, such as the scalp, face, and trunk. There is known to be an association with skin yeasts of Malassezia species. This is thought to be due to a reaction to the yeast rather than a simple infection. Overactivity of the sebaceous glands in the newborn may be a factor to cause the yellow, crusty, greasy scaling on the scalp and is known as the cradle cap. Scaly, greasy patches form on the baby's scalp, the forehead, eyebrows, behind the ears, sides of the nose, middle of the chest, umbilical area, intertriginous, and perineal areas in the infants are also affected. There is considerable lack of pruritus. The patches become thick and crusty, but the cradle cap is harmless and non-pruritic. Cradle cap usually goes away on its own within a few months. In the majority of cases, it is a benign, self-limiting condition which usually clears spontaneously during the first 8 to 12 months of life. Most appropriate management is reassurance for the parents that the condition is not serious and will disappear on its own in good time. Recurrence during childhood and adolescence are common due to hormonal changes. Seborrheic dermatitis is managed with treatment that reduces the level of skin yeasts and seborrhea. These include creams and shampoo, which can be used safely on a long-term basis. Mild steroid creams can be used for short periods to settle any irritation. In patients with persistent rash associated with anemia or adenopathy, always rule out histiocytosis. Contact dermatitis refers to inflammation of the dermis and epidermis as a result of direct contact between the substance and the surface of the skin. Substances that are responsible of contact dermatitis in pediatric age can be irritant as chemical or physical agents that causes irritant contact dermatitis or sensitizers that cause a tissue inflammation damage with allergic mechanism or allergic contact dermatitis. The acute phase is characterized by the development of erythematous indurated scaly plaques with severe cases demonstrating vesiculations and bullae. Affected sites often mimic the pattern of exposure and may provide insight into the allergen source and elicitor of the disease. Repeated or continuous exposure of sensitized individuals to the allergen results in chronic disease, which is usually marked by lichenified erythematous plaques with variable hyperkeratosis, scale, and fissuring. Exposed areas of the body that comes into contact with the environment are likely sites for allergic contact dermatitis. This table summarizes the difference between allergic and irritant contact dermatitis. The absorption of substances in contact with the skin is greater in newborns and infants for 3 reasons. Their skin is thinner, there is a high ratio between the surface of the skin and the body weight, and the skin is covered by a sort of down that increases the absorbent surface. There are 2 parts to addressing contact dermatitis. First, treat the irritated skin. Next, determine what caused the reaction so you can avoid that allergen or irritant in the future. Topical corticosteroids are the mainstay of treatment, while a variety of symptomatic treatments can provide short-term relief of pruritus. If the rash is extensive or involves genitalia or the skin around the eyes, oral steroids given at 1 to 2 mg per kilogram per day for 1 week is advised, and then wean during the 2nd week. Most children will have a skin infection at some time. Skin infections are a common reason for consultation in primary care and in dermatology practice. Impetigo is the most common bacterial infection in children. This acute, highly contagious infection of the superficial layers of the epidermis is primarily caused by Streptococcus pyogenes and Staphylococcus aureus. Children commonly have multiple coalescing lesions on their face and extremities or in areas with a break in the natural skin defense barrier. The initial lesions are small vesicles or pustules that rupture and become a honey-colored crust with a moist erythematous base. This is the hallmark for impetigo. Impetigo is usually a self-limited process that resolves within 2 weeks. Acute post-streptococcal glomerulonephritis is a rare complication of non-bullous impetigo from nephrogenic strains of the Group A beta hemolytic streptococcus. Bullous impetigo is considered to be less contagious than the non-bullous form. It tends to affect the face, extremities, axilla, trunk, and the perianal regions. The initial lesions are fragile, thin-roofed, flaccid, and transparent bullae with a clear yellow fluid that turns cloudy and dark yellow. Once the bullae rupture, they leave behind a rim of scale around an erythematous moist base but no crust, followed by a brown lacquered or varnished type scalded skin appearance, with a collarette of scale or a peripheral tube-like rim, termed as impetigo circinata. Extensive lesions in infants may be associated with systemic symptoms such as fever, malaise, generalized weakness, and diarrhea. Rarely, infants may present with signs of pneumonia, septic arthritis, meningitis, or osteomyelitis. Treatment of impetigo typically involves local wound care in conjunction with either a topical antibiotic or a combination of systemic and topical agents. In general, the antibiotic selection has coverage against both Staph aureus and Strep pyogenes. Ecthyma is an ulcerative pyoderma of the skin well known to be caused by a group A beta hemolytic streptococci. Concomitant Staph aureus is often isolated from lesional skin. Pre-existing tissue damage such as excoriations, insect bites, other dermatitis, and immunocompromised states like diabetes, neutropenia, etc. predispose the patients to the development of ecthyma. Spread of skin streptococci is augmented by crowding and poor hygiene. Ecthyma extends into the dermis. It is often referred to as the differ form of impetigo. Removal of the crust results in the superficial sausage-shaped ulcers with elevated edges and raw base. Ecthyma lesions are slow to heal but do respond to appropriate antibiotics and local wound care. Prognosis is favorable. Children with superficial fungal infections are commonly seen in clinical practice. At times, diagnosis can be a challenge, but is made easier with the use of potassium hydroxide microscopy and fungal cultures. The common dermatophytes, Trichophyton, Microsporum, and Epidermophyton are major causes of superficial fungal infections in children. These infections are typically acquired directly from contact with infected humans or animals, or indirectly from exposure to contaminated soils or fomites. Tinea refers to dermatophyte infections, which are generally classified by anatomical location. Tinea Capitis is located on the scalp, Tinea Pedis on the feet, Tinea corporis on the body, Tinea cruris on the groin, and Tinea unguium on the nails. Superficial tinea infections are some of the most common dermatologic conditions in children. Tinea capitis is the most common fungal infection in children. Clinical presentation of Tinea capitis varies from a scaly, non-inflamed dermatosis resembling seborrheic dermatitis to an inflammatory disease with scaly erythematous lesions and hair loss or alopecia that may progress to severely inflamed deep abscesses termed chorion, with potential for scarring and permanent alopecia. The type of disease elicited depends on interaction between the host and the etiologic agents. Tinea capitis causes the gradual appearance of round patches of dry scale, alopecia, or both. Trichophyton tonsurans infection causes block dot ringworm in which hair shafts break at the scalp surface. Microsporum odoni infection causes gray patch ringworm in which hair shaft breaks above the surface, leaving short stubs. Inflammatory Tinea capitis begins as erythematous, scaly, papular eruptions with loose, broken-off hairs. A buggy, edematous, painful plaque is called a chorion. While favus characteristically exhibits multiple cup-shaped yellow crusts known as scutula. Oral antifungal therapy is the primary treatment for Tinea capitis. Patients usually respond well to treatment. Tinea versicolor is a common, benign, superficial cutaneous fungal infection usually characterized by hypopigmented or hyperpigmented macules and patches on the chest and the back. Most individuals with Tinea versicolor report cosmetically disturbing abnormal pigmentation. The color of each lesion varies from almost white to reddish-brown or fawn-colored depending on one's skin color. A fine, dust-like scale covers the lesion and is elicited through gratinage maneuver. There is mild pruritus and minimal inflammation. The KOH finding of spores with short mycelium has been referred to as the spaghetti and meatballs or the bacon and egg sign of Tinea versicolor. The upper trunk is most commonly affected, but the lesions often spread to the upper arms, antecubital fossa, neck, abdomen, popliteal fossa, and intertriginous areas. Residual hypopigmentation without overlying scale may remain for many months following effective treatment. This is due to the fungus compelling the production of abnormally small melanosomes which are not transferred to the keratinocytes properly. Tinea versicolor can be successfully treated with various agents. Effective topical agents include selenium sulfide, sodium sulfacetamide, cycloperoxylamine, etc. Oral therapy with systemic antifungal is effective for Tinea versicolor and is often preferred by patients because of convenience, and oral administration is less time-consuming than the topical treatment. Viral infections with purely cutaneous involvement includes Molluscum contagiosum and the common warts. Molluscum contagiosum virus causes a benign viral infection that is largely a disease of humans. Molluscum contagiosum virus causes characteristic skin lesions consisting of a single or more often multiple rounded, dome-shaped pink waxy papules. The papules are umbilicated and contain a caseous plug. The prognosis in Molluscum contagiosum is generally excellent because the disease is usually benign and self-limited. Spontaneous resolution generally occurs by 18 months in immunocompetent individuals. Molluscum contagiosum in adults are usually sexually transmitted. Intervention may be indicated if lesions persist. Therapeutic modalities include topical application of various medications, radiation therapy, and/or surgery. Each technique may result in scarring or post-inflammatory pigmentary changes. Frequently, multiple treatment sessions are necessary because of the recurrence of treated lesions and/or the appearance of new lesions. Warts or verruca are very common, harmless skin infection caused by human papillomavirus. Common warts or verruca vulgaris are irregularly surfaced, dome lesions that can occur almost anywhere in the body. These are characterized by the tiny block dots on the surface with thrombosed capillaries. Multiple warts are common and are spread by skin-to-skin contact or contact with a contaminated surface. After initial infection, warts frequently are spread by autoinoculation from scratching, shaving, or other skin trauma. Treatment options for warts include mechanical destruction and adjustment of the patient's immune system through medications and observation. The most commonly employed treatments involve destroying the affected tissue by freezing, burning, curating, electrodesiccation, or applying topical acids. Chemotherapeutics are sometimes used in refractory or severe cases. Children are usually affected by infestations, common of which include scabies and pediculosis. Scabies is a contagious skin condition caused by small mites or the Sarcoptes scabiei var hominis. Symptoms and signs of scabies include generalized intense itching. The condition is sometimes called the 7-year itch. Symptoms and signs of scabies on the skin vary and may include short, linear, or nodular burrows between the fingers, tiny red bumps and blisters on the skin, or a widespread crusted rash. Sometimes there are no visible skin lesions. The mite is spread from person to person by skin-to-skin contact. Scabies treatment involves eliminating the infestation with medications. Medications commonly prescribed for scabies include the following. Pediculosis infestation can involve the head, termed as Pediculosis Capitis, the body, Pediculosis corporis, or the pubic area, also known as Pediculosis pubis. The main mode of transmission of head lice is contact with a person who is already infested. The majority of head lice infestations are asymptomatic. When symptoms are noted, they may include a tickling feeling of something moving in the hair, itching caused by an allergic reaction to the louse saliva, and irritability. Secondary bacterial infection may be a complication. On examination, look closely at the occipital and retroauricular area where you will find live needs on the proximal hair shaft. Those with evidence of an active head lice infestation should be treated. Besides, it is imperative to screen all household members and other close contacts. Prophylactic treatment may be considered for persons who share the same bed with actively infested individuals. Infection with Mycobacterium tuberculosis and the inflammatory reaction of the host define the disease. Tuberculous chancre and affected regional lymph node constitute the tuberculous primary complex in the skin. Children are most commonly affected with predilection to the following sites. Tubercle bacilli are introduced into the tissue at the site of minor trauma. Chancre appears 2 to 4 weeks after inoculation. Painless ulcers characterized as shallow with granular or hemorrhagic base studded with miliary abscess or covered with necrotic tissue. Undermined ragged edges and reddish-blue hue indurated with thick adherent crusts. The mucosal lesions are characterized as painless ulcers or fungating granulomas. Lymphadenopathy is characterized by slow progressing, usually seen 3 to 8 weeks post-infection, that turns into a cold abscess that perforates into a sinus. Untreated tuberculous chancre condition lasts up to 12 months. The regional lymph node usually calcifies. Scrofuloderma is a subcutaneous tuberculosis leading to cold abscess formation and a secondary breakdown of overlying skin. Scrofuloderma most often occurs in the parotid, submandibular, and supraclavicular regions and may be bilateral. Spontaneous healing thus occurs, but the course is very protracted and it may be years before lesions be replaced by scar tissue. Thank you for your utmost focus and attention. Please answer the post-test, all for the Filipino child.